Good morning and welcome to a special edition of IIMHCO's Maternity Natural Health webinar with Kathy Fray. I'm Julie. I'll be hosting today while Kathy answers the 3 commonest questions mothers-to-be post on Ask the Maternity Gurus and the 4 never asked questions mothers-to-be hardly ever post on Ask the Maternity Gurus, which are the questions that they really should be asking. So first up, welcome Kathy. Thank you for inviting me to host today. I'm really looking forward to these questions and hearing what you've got to say here. It's a bit of a different topic for our webinar, and I think that we need to start with the obvious question, which is what is Ask the Maternity Gurus?
Yeah, that's a good one. Yeah, so that's a Facebook group that myself and an Australian obstetrician originally created, and it's sort of just really gone from there. And now we've got other maternity healthcare professionals from different modalities, including yourself, who contribute to it. And we've never actually marketed the Ask the Maternity Gurus Facebook page, but somehow the word has just spread, and we've got nearing 10,000 members on there now. And basically what we do is provide some free advice to women who are in situations where maybe they are really struggling to receive some great advice. Or any advice sometimes. Yeah, so although, you know, we both are, you know, New Zealand and Australia, where we're both based, you know, we are countries that have access to good maternity health care in general, but that's not the case for a lot of women on the planet. And yeah, so that's what we do, and we just volunteer our time and help sort of smooth the edges for some women. And most things are not that serious, but sometimes we get some really serious stuff that they're wondering if it's serious and it's actually really serious. You know, yeah. So hopefully we are making some differences in people's lives. So it's, yeah, it's just a volunteer team. I don't know, it's maternity experts across borders kind of virtually.
Yeah, yeah, really important information to access for women, I imagine, particularly during the COVID lockdowns. It was a lot more difficult for people to access services, and I think that well, there were a lot of women that went with questions unanswered from their maternity care providers during that time.
Yeah, they did. And interestingly, we started it before COVID, but boy, hasn't the, you know, accessing information virtually has just gone from, you know, hardly anybody knowing what a Zoom is to the whole world knowing what a Zoom is.
That's right.
So it's really changed, isn't it, the environment? And yeah, but we also have to be careful that we're not overstepping the mark, you know, because obviously we're not seeing women in person, but you know, we've got some very senior maternity health professionals on board, and they know, you know, when it's appropriate and inappropriate, you know, to be giving some guidance virtually.
Yeah, so a really good team of women with good professional ethics, and yeah, they know how to. And men. That's right. The founder, our founder.
One of our obstetricians is a man. We need to include him. It's always actually made me giggle over the years as a midwife. You know, we have a handful of male midwives in our country, and I remember people going, God, you know, how could you be, how would you want a male midwife? He's clearly not given birth. And well, yes, but we have male obstetricians and nobody thinks anything about that.
That's
or
true.
Male gynecologists. Yeah, it's quite funny.
Yeah, it is. It's very true. I had a male midwife during my pregnancy, not actually there for the birth, but supporting me during my second pregnancy. And he was wonderful. I would have felt completely comfortable with him during a birth, I think.
Yeah, it's quite funny, isn't it?
It really is.
Maybe it's just the word midwife, but yeah.
Yes.
Midwife, of course, just means with women. So yes, if you're a male midwife, you are still a midwife.
Yes,
Not
you
a
are.
husband. Yeah, so I guess we should get on with it.
Yes, so
screen.
Okay, share your screen. If anybody has any questions, pop them in the chat box for us and I'll make sure that we cover them. All right, Kathy. Actually, Kathy, we're going to get started here. I just wanted to see if you could give us a bit of an introduction for yourself and what you're going to cover today.
Yeah, sure. Can you see my screen okay?
Yep.
Is that the large screen?
I can see it perfectly. It is. Yep. You've got.
Perfect. Yeah, so to say what we're going to do, I sort of started this presentation thinking that I'd do the 10 most top questions, or something like that, but I really sort of changed it along the way to sort of say the 3 commonest questions that we just get posted all the time, and the 4 questions that we should get that we don't get. And what's so interesting, I think, for mothers to be watching this is you're going to have some answers that to things that you maybe didn't even know you should be asking,
Yep.
And for our health professionals, I think it's fascinating. Certainly we've found it fascinating on the forum as to how so many women don't know some of this information. And yeah, so it's interesting, but just a little bit of background on me. So I am a semi-retired midwife. I've also been New Zealand's #1 birth baby motherhood author since 2005. And I'm the managing director of MotherWise. So MotherWise.co.nz or motherswise.com. We have a huge amount of resources there, basically, for women, a lot that are free, some that are purchasable. And then, of course, with working with Julie, I'm the founding director of IIMHCO, which is the International Integrative Maternity Healthcare Organisation, and we're global thought leaders on perinatal integrative medicine. And of course, these are, our weekly maternity natural health seminars that we have. So that's a little bit about me.
Thank you.
Yeah, and actually I will just throw in there that for those mothers to be that are watching, over the course of COVID, we have created, or I have created with MotherWise, a new MotherWise Masterclass online advanced prenatal education program. So, I can't recommend that enough as far as sort of going deep diving into information. So if you're a woman who wants to know everything about everything, and actually every woman should be like that, and these questions will show that.
That's true. And I've had a look at the course, and it's everything Kathy says it is. It's a really wonderful resource.
Thank you. It's just, making such wasn't it such a change in the environment where we'd gone from women learning so much of this prenatal education sitting around in a classroom situation with 10 other couples or whatever it is, and now we could be years off a pregnant woman feeling comfortable doing that anymore. So
that's true.
Yeah, it's really tricky.
And she has all the information she's looking for at her fingertips.
The
internet.
Yeah, and Dr. Google is not
always your friend.
Yeah, not a great resource, that's for sure. I mean, there's good information, but it's impossible to identify it out.
That's right. You've got to know how to.
It's completely in Greek.
You've got to know how to find it and how to identify it. That's right. So
yeah, okay.
Kathy's going to give us good information.
So we'll go on to the first question. question. Now, we get questions that are, I mean, I'll read through this one, but we get all different variations on basically the same theme. So something along the lines of, my period is 8 days late, but we use the withdrawal method and we thought none of our partners got inside me. Yes, we get really specific questions sometimes. I took 4 home pregnancy tests late last week and they're all negative. Then today I did 2 more and there were faint lines on both. I don't get what that means. I've vomited too, more than once. I've lost my appetite and I think my boobs are sore. It's hard to tell as I bought a new bra and it's a bit firm. Plus this morning I slept through my alarm because I was tired and that's not like me. But then again, I did binge watch a TV series late last night and my stomach has been hurting, but I did a lot of crunches at the gym. So I'm not sure if that's what it is or if I'm pregnant. Did crunches hurt my baby? I'm exercising on an empty stomach too. Oh my God, do you think I could be pregnant? I'm so worried. Is this normal?
Oh, I can just feel the anxiety dripping off this.
Yeah. And basically we get a lot of questions where people have got all these details and all these symptoms and all these everything going on. Mm-hmm. But at the end of the day, they're asking, am I pregnant? Could I be pregnant? I'm so worried. Is this normal? Yep. And that's mm-hmm. sort of what comes out of all of that. So for so many women to be wondering, am I pregnant? Could I be pregnant? And basically, well, if you've had sexual intercourse, yep, you could be pregnant.
That's how it happens, ladies.
That answers that question. Yes, you could. Obviously there's some rare exceptional circumstances that, but generally, if you think you could be pregnant, well, then you could be pregnant.
Yeah.
Okay. So the next question is, how do you confirm that you're pregnant? And obviously women do home pregnancy tests, but we know that it's all, another thing we'll often explain is that although it's very possible to have a false negative home pregnancy test, it's really not possible to have a false positive. So when it says you're pregnant, then you're pregnant, because often women will get a test that says they're pregnant and then they go and do the test another 6 times. They'll buy another 3 packets of 2-pack things and they'll retest themselves. Am I really pregnant? Yes, you are. Gosh, I wish that on the back of the packaging of the home pregnancy test, it said something simple like that if it's possible, that it's possible to be pregnant and have a negative result, but if it says you're positive, it's positive.
That's right.
But we, in the circumstances when we've got women who aren't sure, that they think that they are pregnant, but the test continues to say negative, then the obvious thing that they need to do is have a blood test or an ultrasound scan. Yeah. And this theme of I'm so worried, is this normal, is absolutely phenomenally throughout the questions. I'm so worried, and is this normal? But we'll go on to the next question.
Well, I think I'm so worried and is this normal is a theme that stays with a woman from the time that she finds out that she's pregnant or the time that she decides that she wants to get pregnant to, I don't know, my oldest son's now 20. So the concern and the anxiety stays with you.
It's true. Yeah.
During pregnancy, it's very common and very normal to be worried, and it's a really great time to be looking at strategies that you can use to help manage that anxiety throughout pregnancy and while you're learning the ropes of motherhood.
Absolutely. And because there is just such a theme of that, and you're right. I mean, we're going to be worried about our babies the rest of our whole lives. In fact, probably from beyond our own graves, we'll still be worrying about our children. So it makes us a good mum, it makes us a good parent, but it's keeping that balance, which I'll head into. So the next commonest question that we get is, something along these lines of variables. I was positive with a home pregnancy test, but at my 5-week scan, they said they couldn't see a pole inside the gestational sac. What does that mean? I looked this up on Google and it says no pole is a blighted ovum. Oh my God, have I miscarried? And when I read my scan report, it says I have a cyst on my left ovary, but the lady doing the scan didn't mention it at all. Could I have cancer? I can't sleep properly and can't focus at work. At the scan, they just told me to come back in 2 weeks' time. Why? Has my baby died? And why didn't they tell me about the cyst? I'm sure they should have. Now I think about it, I have been getting aches on my left side too. And why can't they see my baby when my home pregnancy test was positive? Could I have miscarried already? Maybe I have an ectopic pregnancy. It's all worsening my anxiety. I'm so worried. Is this normal?
Yeah. And again,
so
much anxiety.
Yeah, again, we've got the theme of I'm so worried, is this normal? But there's so much misunderstanding around ultrasound scans. And, for any sonographers or radiographers who are watching this, please, can you realize how much concern that women walk out with from the slightest little comment that you can make sometimes? And what they're there for is reassurance. And I know that you do loads and loads of scans and it all gets pretty but this we sort of end up coming in as midwives and obstetricians as doing almost damage control on the results of that scan. So firstly, seeing the fetal pole, which basically is saying that seeing the embryo inside the gestational sac, that is something that can be tricky to see at 5 to 6 weeks gestation. Usually by 7 to 8, we really should be able to see it by then. But there's so many variables that when women are basing their gestation on their LMP or last menstrual period, that's estimating when they ovulated. We don't really know absolutely necessarily when they ovulated, and of course when they conceived could be a few days after they ovulated. So the gestation that we're estimating that they are before a scan may be different to the gestation they are in the scan. So let's say the woman thinks that she's 6 weeks and actually she's 5 weeks, and maybe that's why we're not seeing it. It also comes down to maternal habitus, or how big you are, ladies, how much adipose tissue there is, and the quality of the actual ultrasound gear. So obviously what we've got all different levels that can sort of portable type ultrasound that they have in their office, and then you've got larger ultrasounds at say radiography type clinics, and then we've got a very high level, a tertiary level, secondary care level ultrasound machinery or equipment, in big hospitals. So we've got all levels of visibility basically, and bearing in mind that when a baby is 5 or 6 weeks old, it is only the size of a grain of rice.
Pretty hard to see.
Yeah. And it's hard for the imagery to pick up the heartbeat, which then confirms a viable pregnancy. That's only the size of a strawberry seed. There's little black seeds on the outside of a strawberry. So you're trying to see a strawberry seed beat within something the size of a grain of rice. And, so it's absolutely very common that women go and have that very first, what we call dating scan, and they can't confirm at that time that the pregnancy is viable, meaning they're not seeing that grain of rice with its beating strawberry seed. And we need that woman to come back, a couple of weeks later to be able to get that confirmation of viability. And also the cyst on the ovary. Gosh, that's just so often women get worried about that. Oh my God, I've got a cyst on my ovary. Not all cysts are of concern in your body, not at all. And that is what we call the corpus luteum cyst, and it is what forms as part of the pregnancy, and it is what maintains the pregnancy. And while the placenta grows, because you have to in that first trimester grow a whole new organ in your body for your baby, or your baby is the baby's placenta. So while that placental organ is growing, the corpus luteum cyst maintains the pregnancy. So we want to see that cyst, and it tells us
to see.
Yeah, and it tells us which ovary you ovulated from too. So yeah, all very normal. But again, we've got this, I'm so worried, is this normal? Is this normal is a really common thing that women ask. And often we need to reply, it may not be quote unquote normal, but it's very common. Yes. So it's, yeah, and that's a different thing as well. And I'm so worried, anxiety, we know that stress impacts pregnancy well-being enormously. And if there's one thing that women can do is not be stressing. And we know that's hard because you're all anxious and worried about your baby, and sometimes women are anxious because they didn't plan to be pregnant.
Yeah.
Sometimes women are anxious because they want to be pregnant.
And it's all just such a different situation, new, and even if it's your second or third pregnancy, it's still something, it's still very anxiety provoking.
It is. And so, but I would say to women, it's so important that you keep your stress in check for the health of the pregnancy. Yeah. So, and we'll go into that in a bit more detail. So we'll go to the next question. Question 3. I've not long found out that I'm 7 weeks pregnant, and now I've had some weird discharge. 2 days ago, it was mostly brown, but then some pink stuff after I wiped going to the loo, and I read online that's a probable miscarriage. So I went to the ER. They saw the baby's heartbeat and sent me home saying everything was fine. Yesterday evening, I got some red spotting. So I urgently rang the doctor, and he seemed pretty angry. I was calling him at night. But I went for another scan today, and the report says there's a chorionic hemorrhage. Oh my God, I'm freaking out. I'm so anxious. I don't know what to do. I'm so stressful. Am I losing my baby? I hadn't planned this pregnancy, but now I really want this baby. I'm so worried. Is this normal?
Oh,
yeah. So this is a hard one from the point of view that having spotting and in early pregnancy can never be regarded as normal, but it is very common.
Yeah.
And somehow, if we could only get to these women, if you've had any contact as a health professional with a woman who's found out that, and she's very early in her pregnancy, this is one of the things, the first thing that we should be discussing with them is what to do in the situation of wondering if you have a threatened miscarriage or a miscarrying, because that's obviously what people are worried about. So we always explain that no spotting or bleeding or abdominal pain in pregnancy is normal, but we can't regard it as normal, but it is incredibly common. And in that first trimester, the body is working so hard to try and maintain or successfully establish that pregnancy, bearing in mind that around 30% of pregnancies naturally miscarry. so that's just what happens in human reproduction. In fact, going further before that, around 70% of fertilized eggs never implant, and around 30% of implanted eggs naturally miscarry. So Mother Nature is looking for her goal, 99% of the time, not 99%, but 90%, anyway, a high level of the time, she's looking for perfectly normal. That's what she's looking for. And so whenever she senses something's not quite right, she will naturally miscarry. And it's an awfully, incredibly tough thing for a woman to deal with. But somehow, if we can get it across that to accept that this is part of human reproduction, it's what occurs. Certainly, if a woman has 3 or more recurrent miscarriages, falls pregnant, miscarries, falls pregnant, miscarries, falls pregnant, miscarry, that's not normal. But yeah, so that's the first thing, is to realize that this is part of normal human reproduction, tough as it is. And I think it's tougher on our women these days because we've got such early ways to confirm pregnancy, whereas in our great grandmothers' days, well, they didn't know for sure till way down the track. So they would have, a late heavy a late heavy period, and sort of scratch their head and go, was that a miscarriage? My cycle's like 3 weeks late and it's a much heavier bleed than normal. Maybe, they'll never know. But for us these days, we have these incredibly early scans, these incredibly, generally sensitive home pregnancy tests. So suddenly we know, and it does make it tricky.
It does.
So the next reality that's tough is that there is nothing that obstetric medicine can do to prevent a miscarriage. So running off to the ER, there's nothing they can do. Once we get past 20 weeks, generally around the world, every country can be a little different, but there's a bit of a line in the sand where before that date is regarded as a miscarriage, after that date is regarded as preterm labor. But generally speaking, it really is not until a woman is around 24, 25, 26, 27, 28 weeks that there may be, that's when it is normal that there are things that modern medicine can do, give her tocolytics basically, which help to stop her womb contracting in the hope of extending her pregnancy so her baby can be born less prematurely. But until that baby is at a viable age to live, there is really virtually nothing that is done. So the best thing that women can do when they are bleeding or cramping in early pregnancy is to rest. That is the number one first thing, is stopping whatever they're doing and rest until it stops, until the bleeding stops or until the pain stops. If the woman is having a level of bleeding that could potentially require her to have a blood transfusion, so something like, filling a pad in half an hour, if a woman's having that level of bleeding, she should she needs to go to the emergency department in case she needs a blood transfusion. Or if a woman is having abdominal cramps that are so severe that they're actually really full-on active contractions, and she potentially needs some pain relief like morphine, then that's when she should absolutely be going to the emergency department. So it's really if she needs a high level narcotic opioid pain relief or she needs a blood transfusion. Those are the times that it's the right thing is to go to the emergency department. But if you're just spotting or just mildly cramping, then rest is the thing to do. Absolutely don't try and push through it. Absolutely don't stay at work. You need to be lying horizontal bed rest until it stops. And then once it's stopped, then the next day or later that day or as soon as practical without it being dealt with as an emergency, it would be good to go and have another ultrasound scan and to see what's going on.
So rest is your first aid in this situation.
Yeah. And that's where, like taking yourself off at 3 o'clock in the morning to emergency department and sitting upright in the waiting room for 6 hours because no one's going to be treating you as much of an emergency when you explain you're 7 weeks pregnant and you've had some spotting. You're going to be sitting there for a while usually. That's kind of the worst thing for your body. You want to be horizontal and resting.
Yeah.
So those are those top three. And when we so the I'm so worried and is this normal? So is it normal is very different from is it common?
Good distinction.
And then the I'm so worried. The things that we often suggest, I often find myself suggesting about managing that worry because those worries are throughout the entire pregnancy. So we always get I'm so worried about this, and it doesn't matter if they're 8 weeks or, as you say, 28 weeks, 38 weeks. But that stressful anxiety is something we need to get hold of and deal with. So it's one of the easiest strategies can be basically to proactively distract yourself. So, it might be mindfulness, a gentle walk, talking to your baby, reading a great book, watching a feel-good movie. You need to just say, what can I do to get my mind off this?
Yeah.
That's really typically the easiest way to. Have you got any other things that you'd contribute on that about managing worries?
Well, I like to get people to write their own little pick list. So to think about things that that help them to feel less anxious and things that can typically distract them. I like people to have a list of 10 things that they can look at so that they can go, okay, no, at the moment I don't feel like doing that, but maybe I can go for a walk, or okay, maybe I can go and lie down and read in bed or something like that. I like to teach.
So they have their own list and they'll look on their list like a shopping list. What do I feel like? Or
that's
a menu.
Right. That's right. I think that there's some nice meditations that I like to tool people up with. Like I like to give people some really solid tools. And I think just one little meditation that you can do, just 10 minutes that you can use as like a little bit of a rescue when you're feeling that overwhelm. It's a really good way to interrupt that really intense feeling of anxiety.
That's right. And that's the thing, is saying to yourself, look, I know I'm anxious, so I'm going to proactively manage this. Because remember when as you know, but when a body is trying to establish a pregnancy, if it feels like this is a stressful situation, that's one of the biggest reasons it won't successfully establish the pregnancy, because it's looking for a calm environment to go, yes, because the woman's body committing to that pregnancy, this is not something that she's committing to, for the next couple of days her body is committing to the pregnancy for the next 8 months, and then a year of breastfeeding and 18 years of raising a baby, so to speak. So it's a huge commitment. So the body's looking for the optimum situation to go, yep, this is all good, let's continue with this pregnancy.
And that's generally not when you're in a very high stress situation. So teach your body to feel calm.
So those are the 3 biggies that are just really, so obviously they're really all about the very beginning of the pregnancy. And then what seems to happen on the Ask Maternity Gurus is we lose people for a while. It's sort of like once they get past that, they kind of slide out of the radar for a while, particularly in that second trimester, not always, but just generally. And then it's the 3rd trimester when women will start to have other concerns. But the second trimester is so valuable for them to get information for ahead of them.
Yeah, and it's a time when many women are feeling quite good and energetic and feel that they have the resources to put into a little bit more education.
That's right, but disappointingly, how few do. So yeah, which is what we're kind of coming to now, is the questions that we really get asked. So I have just found out I am pregnant. Is there anything I should do or should not do to help avoid a miscarriage so this pregnancy can successfully establish?
Great question.
Right? Instead of that's, asking that prevention question rather than, oh, I've got spotting, what do I, so answers on that one is again, we've sort of covered some of this off already, but appreciate that the statistics of Mother Nature's human reproduction, the fact that 30% of implanted eggs naturally miscarry. Rest, 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 sleep, sleep, sleep. De-stress, de-stress, de-stress. Worries, which we covered, but women of, we can be surprised by how incredibly tired we get in that first trimester. And this is Mother Nature's way to make you slow down, do almost nothing, so she can successfully establish the pregnancy. It's really very equivalent to when we have a cold or a flu and all we want to do is lie in bed because we feel sick, or if we have an infection, we just want to lie down because your body wants you to stop doing everything else so it can focus. It wants you to rest, it wants you to sleep, so that it can focus on doing what it's trying to do. It's not trying to cure you from a cold, it's trying to establish a pregnancy.
Redirecting
and
resources.
Women can tend to feel obligated. They can feel obligated to push through that tiredness, especially when they're at work, when they're not ready to tell work colleagues yet that they're pregnant, and that becomes kind of tricky. But it's so important. And then the other big thing, if the woman has not already been doing this as part of her preconception health care, which is like one of the best things you can do for establishing a healthy pregnancy, is be doing preconception health care. For sort of 3 to 4 months minimum for the guys, and 6 to 12 months preferably for the girls. Because we know that the health of the sperm and the health of the egg makes such a big difference.
And the overall health of
actively
the body.
So if they have not already done that, yes. So actively supporting your body's well-being in their early pregnancy. So visiting a qualified naturopath, wellness specialist, so it might be a medical herbalist, classical homeopath, maternity acupuncturist, or even better, see all 3. But be proactively doing what you can to promote your wellness of the pregnancy.
Yeah, I think that's really important. And it's great to establish a relationship with these types of practitioners early on, because often where medicine has nothing to offer, there are things that can be done to support the pregnancy.
It's absolutely true. Yeah, and there is often a feeling that obstetric medicine has all the questions, has all the answers to all the questions. And having been a university research midwife myself at one point in my career, I can tell you, boy, obstetric medicine sure as heck does not have all the answers.
Lots of questions.
Honestly, the more that we study, the more we realize we don't understand. The more maternity physiological studies that we do, the more questions that we end up, we go into research wanting to answer this question, and we come out of that piece of research with 5 new questions.
That's how you know you've got a good piece of research. That's how it's supposed to work. But so many questions, so few answers.
It's exactly how, but it is. And so just do know that obstetric medicine knows a lot, but boy, it's also very aware. There's it's more aware of what it doesn't know than what it does know, in a lot of ways. So next question: with being pregnant, I am thinking of stopping work a month before I'm due, but when is the best time to stop work? I can't believe how rarely anybody asks that question.
Well, I think that people feel that they don't have a lot of choices some of the time when it comes to this question, because people are having to choose between taking maternity leave before their baby's born so that they get a chance to rest the end of their pregnancy, or to spend more time as a full-time mother before they go back to work.
Yeah, they do. And on top of that, but what is surprising is that, because that's all financial based.
That's right. Yep.
And it would be so nice to have the question asked beyond the financial question.
Yes.
Right. And because I'm in that old school category where there was no maternity leave. So we just, me and my girlfriends, well, we just all were broke. All the couples were broke, and you would buy everything secondhand. And so I do find it very frustrating when women are talking about their necessity financially to be at work, but they're out buying a brand new cot and a brand new pram, because that's not the priorities that the baby wants. In general terms, I do get this question. So firstly, your body needs to rest. And basically what I generally say is from 28 weeks, work part-time, and from 32 weeks, not working at all. But the thing that we know is that stress in pregnancy increases 4 main areas of serious obstetric concern. 1, preterm labor of a premature baby. 2, gestational diabetes. 3, preeclamptic toxemia. And 4, growth restricted babies from placental insufficiency. That is the big 4 that we have. I can say hand on heart that in all my years as a caseloading midwife, I have never, that every single woman who has ever had a premature labor was working full time.
Wow.
Every single one.
Gosh, that's a big call.
Yeah. So and there's also this general misunderstanding as to what a due date is. So when a woman's got a quote unquote due date, it's a terrible name for it. It's not what it is.
It really is.
It's actually an estimated 40-week gestation, right? Yeah. It's not a due date. It's an estimated due date, but it's not even that. It's a 40-week gestation estimation. And it's absolutely normal to have a baby anytime from 37 to 42 weeks. So when a woman gives birth before 37 weeks, that's preterm, and anytime after 42 weeks is post dates. But 37 to 42 weeks is not early and not late. So when a woman says, I'm thinking of stopping work a month before I'm due, that's not a month before she's due if she's talking about her EDD or her 40-week estimated gestation, because she's due from 37 weeks onwards. So she's talking about giving up work a week before she's due, which is 4 weeks before her estimated due date, which is her 40-week gestation. See what I mean?
I see.
To give up work a month before she's due, I completely agree, and that is around 32 weeks.
Great.
Pretty much a month before she's due. And often these decisions around when a woman is working are made when she's in that first or second trimester, when she's, particularly in the second trimester, when she's feeling quite good generally. And so she's thinking at that point, yeah, well, you know, I'm 16 weeks now, and you know, I can do that through to 36 weeks. That's another 20 weeks. That should be fine. At 16 weeks, you've got no idea how shattered you're going to be feeling by 32 weeks.
Yeah, it's a different headspace.
And so, yeah. So I can't emphasize enough that the decision needs to be made beyond finances. Because trust me, when you were planning to work till 36 weeks, but you've just given birth at 28 weeks, well, you're not going back to work the next day. Somehow the finances will get sorted, and somehow work will survive without you. Yeah. I get passionate on this one.
Yeah.
It's and the thing is that when that woman has that premature baby, or she's got gestational diabetes and now preeclamptic toxemia, and now the baby has to be delivered early, and blah 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 blah. And afterwards, when she's seen that baby in NICU or SCIPO, and it's got all those tubes coming out of it, and in and out, and she looks, and the woman is going, hand on heart, she goes, I'll never do that to a baby again. I will never push past work like that. Never. The mother guilt stays with her for the rest of her life. She always wonders, if I left work earlier, if I hadn't stayed late for that meeting when I was feeling too tired to be there. When women walk in the door at night from work and they're pregnant, and they flop down on the couch and they just go, oh my God, you need to have cooked dinner. I'm so tired. I'm shattered. That's not okay for pregnancy.
You need to catch it before then.
Yeah, you need to catch up. Yeah. We don't want you.
You need to have a daytime nap.
Yeah, you do. Okay.
Which some workplaces can accommodate.
Yeah, and if anything, COVID has probably helped that there's been such a bigger acceptance that so many jobs that we do are able to be done from home. So that's kind of given a little bit level of freedom that we didn't have before, and that might be quite helpful actually.
For some.
Yeah, for some. And I would have to say that some of the worst workplaces, notoriously bad workplaces, have been hospitals. I would say nurses, women that are on their feet all day, pregnant nurses, get some of the least amount of understanding of that.
Yeah, and it's a very high stress, highly resilient environment as well, full of people that are just pushing through.
Yeah, it's true. Yeah. So next question, why do around 50% of birthing women end up with dramatic emergency C-sections and instrumental assisted deliveries using the forceps or ventouse. So I know that we talk about C-section rates, but actually we should be talking about both those surgical and instrumental deliveries. Surgical meaning C-section, instrumental meaning ventouse and forceps. And when we add all of those up, they're all emergency deliveries, they're all dramatic, they're all traumatic. And when we add those up, you know, in those countries around the world who have those C-section rates sitting at around that sort of 30-35%, when we add in the instrumental deliveries, actually it's up to about 50%.
Right.
And that's nuts, right?
It really is.
Yeah. And in countries that have much higher C-section rates, those countries are always without doubt, their maternity health care is privatized. So these are obstetricians who are paid to, not by the health system, but they're paid by insurance companies. And because they do make more money on C-sections than they do in natural birth, and C-sections can be scheduled and done in lovely normal business hours, or natural birth, they need to be on call and are up all night and don't really know when that baby might be born. So because of that, the C-sections are much higher, and there'll always be a reason for the C-section, but a lot of them are rather questionable. So what's the sort of main things? Well, basically what happens is this, what we call the cascade of intervention. So in that labour, so there is some decision to induce the labour, which means to make the body spontaneously go into labour, or there is some decision to augment the labour, which means the labour is already maybe latent, and there's a decision to make it stronger, to become more active labour. So that's the first step, is the inductions and the augmentations. So that can be things like rupturing the waters, using prostaglandin vaginally, using oxytocin drips IV. So there's some decision that's made to induce or augment. And that is the first big red flag. Why is it being done? Is this really best practice? And because once you do that, you're stepping on this journey that becomes really difficult to get off. When there's not necessarily with rupturing of waters, but particularly with oxytocin drips, especially, there is a need for that. At that point, there is a need for oxytocin drip, for continuous monitoring. That's the CTG, where you've got the two belts around you. And so that's going to impact on your ability to mobilize. So women can't get up and about in the same way. Sometimes they can. It depends how good the equipment is. It depends on, again, maternal habitus, how easy it is to continuously pick up that fetal monitoring. But why do we need fetal monitoring with oxytocin drips? Well, that's because we've just taken that labour from low risk to high risk. So that's what we've done. Obstetric medicine recognises that we've just changed the game. We've gone from low risk to high risk, so we need to continuously monitor, because we've just increased the chances of that baby having some fetal distress. And then the next reason that we need it is because doing those things, the rupturing of waters, the oxytocin drips, the prostaglandins, this can increase the contractions. That's what it's meant to do. And those increased contractions beyond what a woman's body naturally normally will do, gradually, as she gradually builds up her own body's ability to mentally and physically and emotionally deal with it all, it suddenly can increase. And so that increases her need for epidural anesthesia. One, because the pain can come on so strong, so sudden. and be so relentless. And also because she's now got this continuous monitoring, so she can't mobilize in the same way, she can't get into the pool, she can't use other ways of managing that pain. But with her having that epidural anesthesia, it reduces her mobilization, because now she definitely can't be walking around. Well, generally there are light epidurals that are used sometimes, but it reduces her sensation. So now what happens is she's going to spend way more time lying on her back, not flat, but she's up in a bed, propped up.
A lot less mobile.
Way less mobile. And when you're mobilizing in natural labor, you lean forward. Everything you want to do is lean forward, lean forward, lean forward, at all different positions, but you always want to lean forward. It's just naturally what your body is wanting you to do. And you lean forward so that the baby's back comes to the back of your belly. And so it's got its head down, but it's got its back to the front, which is what we want. Whereas when you're lying back, well, now we've got a baby that's malpositioning. So we've got way more posterior-ized or lateral-ized. The baby's lying towards the side, lying towards the back with its back. So we've got a malpositioned baby. On top of that, because you're not leaning forward and you're not using that gravity of the weight of leaning forward, we don't have the head of the baby pushing as hard on the cervix as it should be. So that's not helping the dilatation either. So now what we've got is a failure to dilate, or dilatate is the correct word, but a failure to dilate and a malpositioned baby. Awesome. Okay, so now what we've got is an obstructed labor, meaning the baby's not getting in, coming down as it should. It's not descending. We're increasing the length of the labor, and we're increasing the chances of fetal distress. Increasing the length of the labor, what happens there is when we put an oxytocin drip on, I'll go backwards on this. When we put an epidural as cited, that notoriously takes away the woman's contractions. So even if you didn't have an oxytocin drip before that, you're sure as heck is probably going to need one after it. Yeah. And that adds hours to the whole situation. So then when a woman does not have an epidural on board, before she's fully dilated, she naturally usually starts to have this irresistible urge to push. And she'll be breathing through that until she just absolutely cannot, and she'll start to push, and it's time to give birth to this baby, which is wonderful. Whereas with a woman who has an epidural on board, and an oxytocin drip, which is making her contract, once she gets to fully dilated, because she's got such a reduced ability to push, the next thing is that they'll go, oh yeah, she's fully, give her another couple of hours before we start pushing. So that baby head is like literally being, for the next 2 hours but basically the reason that's done is that we need that woman's baby to get descended even lower before she begins to push, when she has an epidural on board, to give her a chance of actually delivering, birthing this baby naturally and not needing an instrumental delivery. But I can tell you that when I was a student midwife, that in all my years as a student midwife, I never saw a woman who had an epidural successfully give birth. She always ended up with either a volituse or a forcip or a C-section, like not one, until my very last month as a student midwife. And I saw a woman who did actually manage to give birth to that baby with an epidural on board, and she had a very severe 3rd-degree tear. So because she just couldn't feel it in the same way to know to when to stop pushing. There's a moment when the baby crowns where we need you to stop pushing. She couldn't feel the sensation in the same way. So not one. And because I went in as a student midwife thinking I'm not that anti-epidurals, but I came out like really anti them, because I'm like, this is just ruining what's going on. Anyway, so then when we have all these assisted instrumental deliveries, which is the baby being sucked out or yanked out. Or we have the emergency C-sections, which is the baby being cut out. It has significant impacts on both the mother and the baby. So statistically, the baby has lower APGAR scores, which are the well-being of the baby in that first minute and 5 minutes, 10 minutes after it's born. We have higher rates of NICU and SCBU admissions. We have, for the babies, we have higher rates of postpartum hemorrhage bleeding for the mother. We have higher rates of ICU and HDU admission for the mother, and we have higher rates of postnatal depression as well in the postpartum. And we have higher rates of failure to exclusively fully breastfeed. So it all impacts it.
Yeah, it impacts really the
when
postnatal
you've got
period.
a baby that's got these marks on it, it's huge, because when you see a baby born naturally, spontaneously, and they come out and they're just so settled and so content. They might cry a little just at the shock of the arrival, but within seconds they chill right down. Whereas those instrumental suck out, yank out babies and the fetal distress emergency C-sections, goodness, they just those babies are screaming. And I think that a lot of them have, especially the von Toos and forceps deliveries, they have headaches, I think, for the next week or two.
Yeah, quite possibly.
Cranky babies, cranky. And we see the bruising on their face and things. Well, it's no wonder. And they won't feed well, and they'll just keep pulling off the latch, and then the mother's recovering from all her physical trauma. C-sections are major abdominal surgery.
No joke.
I know they're common, but they're major abdominal surgery. And in what other situation does a human being in a hospital have major abdominal surgery, and the next thing that we do is hand them a baby and say, here, look after that and feed this baby every 2 to 3 hours, 24 hours a day for the next 6 weeks? Who? It's just crazy. Anyway, okay. So it kind of gets to that point where it's almost, it's how can you not have postnatal depression when you've been through all of that?
Well, that's right. It's a tricky way to start things.
So the last one is, I want to do everything in my power to give my baby the safest and least traumatic birth. What can I do to help? Number one question every woman.
What an empowering question.
Yeah, it's so really asked. But yeah, the things are, and it's really easy. It's birth prep, but it's birth prep physically, intellectually, and emotionally. That's it. So birth prep physically. So that's seeing a naturopath throughout the pregnancy who will prescribe partus preparatus, supplements to ripen your cervix. Because golden rule, the softer the cervix, the quicker the dilatation, the shorter the labor, the better condition of both mother and baby. So it's about taking charge to statistically change our own outcome, really. And one of my people say, one of my favorite products for that is Nature's Sunshine, the brand, which stands for 5 weeks, because you take it in the last 5 weeks, so you take it from 35 weeks onwards. That's one of my all-time favorites. And yeah, but definitely seeing a medical herbalist is just so useful, so good. If you can, that's the best thing. And secondly, birth prep intellectually. So that is getting very knowledgeable about understanding the physiological secrets of how natural labor results in normal birth, such as watching the organic birth videos. So that's one that's on my MotherWise. So if you just go to kathyfray.com, you'll see that information there. So that's a 90-minute video that I put together about labour and birth. Accessing our online MotherWise masterclasses, prenatal education program. Again, so those are two examples, but it's about, if you want normal, you need to focus on natural.
Yeah. And know what normal looks like, and empower yourself with knowledge.
Yes. And the thing that you'll find when you do is that although every woman's birth story is unique, the more you learn, the more you read, the more information you get, the more you see the pattern. And so that when it's your turn, you're going to be less fearful and more relaxed, because the more fear and anxiety in labor, the slower the dilation, because this is not a safe time to give birth as a mammal, right? If the woman's feeling fearful and anxious. So it's about getting you into that place so that when you are in labor, you're feeling actually excited about this baby coming, and you feel confident about the process. You understand where you are in the journey of the labor, because you've learned all about the journey of the 3 stages of labor and the 3 phases of birth. You've learned all about that. So you're less fearful, and you'll dilatate quicker, and you'll give birth more easily. It's just what happens. And preparing emotionally. So this is what I'm talking about there. So taking charge, that like the billions of women who went before you on this planet, you can labor and give birth without an epidural. Of course you can. So many other people have done it before you. Why can't you, when all these other billions of women have done it before you? So it's about you facing those fears to proactively conquer them. So, because knowledge is power. You know, the more you understand what's ahead of you. You know, oftentimes when women are in labor and giving birth and holding their baby, that is the first labor they've ever attended, the first birth they've ever attended, and the first newborn they've ever held.
Yep, it was for me.
Yeah, and that's not kind of normal into how human society has been for tens of thousands of years. You know, it's only 100 years ago, not even that actually, where it would be normal all around the planet that you know, by the time that every time a woman is in labor, you know, the women in the village all come to help, and you know, her grandmother could be at the foot of the bed, and gosh, that's the 50th labor or 100th or 200th labor she's seen, you know, and her big sister's there, she's already had, you know, 6 babies, and her mother's there. Her mother could still be pregnant herself. You know, there was this, and the young ones would be there learning and giving birth. So by the time a woman was in labor and gave birth, she'd seen a lot of labors, she'd seen a lot of births, and but we've lost that. So we need to regain it through prenatal education. Anyway, we've gone over time.
We have, but it's been such a great session.
Thank you. So look, that's everything that I mean, there's so much more we could go into, but we don't have time. And so hopefully that's been a really useful little session today for those birth practitioners, to realize the things that people aren't asking and should be, and do ask a lot that should know. So anything else that you want to
add? Not from me at the moment, but I guess I should let everyone come back for our next webinar. I'm going to be on the other side of the screen as the guest.
Yes, yes.
I'll be.
So next week we're actually reversing this role, and we're going to be talking about using lactation as a reliable birth control. And it is amazing how incredibly reliable it is when you know what you're doing.
That's right. And it's not that complicated.
It's not that complicated. Yeah, it's not. And so that's a really, in fact, I think statistically it's more reliable than most other forms of birth control. So
It is.
Yeah.
It is.
But so thank you everybody for being here today.
Thank you so much, Kathy. Thanks for having us, and thanks for having me.
Thank you, everybody.
And thank you everybody for watching us today. Kathy, I just wanted to just remind everybody that you've got MotherWise there as a wonderful resource for anybody that's looking for further support or further information about any of the topics that you've covered today.
Absolutely. And if you just Google Kathy Fray or MotherWise, you'll easily find the links through to there, and we've got loads of resources online there. So
yes.
Thank you.
Oh, and also another wonderful resource is our webinar page over at IIMHCO. We've got some fantastic resources there, and as we spoke about early on in the webinar, stress management is a really important thing for women to learn, and we've got so many tools that you can look at and share with the women that you support. So yeah, have a look at that webinar page.
So IIMHCO is really designed primarily for birth practitioners and anybody that's a maternity related health clinician. But yeah, we do have loads of webinars there that you guys as health practitioners and birth practitioners can share with your woman. Absolutely. And the woman can look for themselves, because as you've worked out, Julie's part of our volunteer team here at IIMHCO as well. Our precious
and you can
team,
be too.
We have a global team. So you can always look on to About Us on the webpage, and you'll see that our management team here at IIMHCO is from all over the world. Yeah. So thank you everybody for being here, and thanks Julie for doing this together with me today. It was appreciated.
You're very welcome, Kathy.
Wish everybody a nice rest of their week.
Thank you. See you next week.
Bye.
Bye.